was lateral condylasia because it wasn't really right on the bone, although that's a little tender. But the majority of the pain was down here, and at that point I thought it was maybe the radial nerve getting entrapped between the supinator heads. So I did a little bit of soft tissue work, some radial nerve supplies. Didn't really get any better. It actually started getting worse to the point where I was getting radiating pain down in here. Occasionally, I get the same sensation on the left side. I have no other left upper extremity things. When it's here, it's very faint. It doesn't last very long. And then shoulder sore, a lot of tension and tightness up in here. There's a spot kind of in the middle of my rhomboid area that I just want somebody to take an elbow to or something. So it just seems to all be connected.
Absolutely. And when did those symptoms start to get worse and move down towards the pain?
Probably within a few days of noticing this pain.
And do you think there was anything in particular that brought on these symptoms?
I do. I'm embarrassed to say that you guys already did for me. So I got an iPad and I got Candy Crush. And I was getting in this habit at night. I would take out my contacts and I don't see well, so I was holding it really close in bed. So I was propped up against pillows and I was really tight. And that's, I think, the aggravating, I don't know if that's what started it, but that's certainly I've discovered is the aggravating activity.
So have you since sort of limited that activity?
That's crazy stuff. So I no longer do Candy Crush. And I've tried to limit, the Kindle or the checking on my phone at night after I've gotten in that position without my contacts.
Okay, so that's certainly something that makes it worse. Is there any different type of positions or things that you've done to help make it better?
Not really. Well, I shouldn't say that. I have a colleague who I've had do some just manual traction, and that seems to help for a little bit.
Okay. And how long would you say that relieves your symptoms for?
A couple hours.
Okay.
We're usually doing that at the end of the day, so it's hard to tell because then I go home and I get in that position to read.
And do you feel like this pain is limiting you from any other activities that you've been doing?
Yes, that's a great question. I haven't been doing any upper body strengthening in the wellness clinics for like a month because it hurts to grip the weights or the bars. I'm trying to do some modified things that don't require gripping, but even just extending my elbow hurts, which was the other thing that made me think not lateral condylasia. Running on the treadmill, I find I have to keep my elbow bent because if I get into any kind of arm swing, that hurts. So I'm not working out as much as I'd like, and now I'm starting to get just kind of shoulder aches that I think are related to just not lifting.
Absolutely. And do you have any past medical history in pretty much your whole right upper extremity?
I have been diagnosed with BPPV, and it's only in the right ear when I get it. I've never been convinced it's inner ear stuff. I always thought it was somehow cervically related. I have a family history of cervical stenosis. My dad's had surgery twice. That's about it as far as past history that would be relevant. I have Graves' disease, but I don't think that would be cause.
Do you have anything else?
Just rule out some red flags. Are you having any problems sleeping at night?
It's gotten a little bit better at night. You mean because of this?
Yeah.
Okay. Because I'm a 50-year-old woman, so yeah, I have trouble sleeping at night.
Okay. Yeah.
I'm hot. But because of this, sometimes I would actually feel like if I was laying on my elbow, the pain in my elbow would wake me up.
Okay.
And I'd have to shift position. I haven't noticed that quite as much. I do notice things, like as soon as I wake up in the morning, it's stiff, I can't stretch, or if I go to smooth out the sheet to make the bed, that motion hurts.
Okay. Any problems swallowing at all? What about any like nausea or any fainting, random
No.
fainting? No. And dizziness besides the vertigo?
No, and I haven't had an episode of the vertigo for probably about 4 or 5 years. I figured it out after several episodes what activities or emotions bring it on, and I just avoid those.
Cool.
What activities and emotions bring them in?
Wonder who's gonna ask it.
Extension and repeated rotation. So the first episode, I was swimming laps in the outdoor pool 10 years ago in the summers, and finished a lap and just, it hit me. I couldn't open my eyes. I had no idea where I was. The world was just spinning. And then a couple episodes later, working and cleaning out the closet and doing a lot of repeated extensions up high, changing the light bulb once did it for me. So I really just avoid extension, and I minimize particularly any kind of rapid rotation. So if I'm driving and I need to look in the Wegmans parking lot before I back out, I know I get that rotation from lowering my spine. I don't turn my head.
And so both left and right rotation brings that on?
It
or
is, but it
possibly-
only comes in the right ear when I get it.
Are you experiencing any pain now?
Yep.
It's how does your intensity level right your
Just sitting here, I'd say it's a 1 or a 2, but I can make it a 4.
Is that the worst that it typically gets at 4?
No, I
Is
would
it
say
higher?
it gets higher. It could be up to a 6.
What are you doing typically when it gets to that point? Is there
Probably
any-
something more repeated. Gripping hurts. We were talking yesterday. That's another, functional thing. When I meet a new patient, I like to give a real firm grip, and I wince when I do that now. So, but I think if I were to do repeated things long enough, we'd get it up there higher.
What kind of pain would you describe it as?
It's almost like 3 different pains. This is where it started, which isn't as bad anymore, was kind of a hot, inflamed, sore pain. What's in my rhomboid, it feels like a trigger point kind of pain. I really feel like if I could just get in there and work it out, it would get better. This is the pain that's really hard for me to describe. It's not a tingling. It's not a numbness. I don't think I have any difference in sensation. It's a very uncomfortable, it's not really a pain. I don't really have a good word for it. But this is the one that disturbs me the most because it makes me think there's
Is it
more
a
to my
wide
story.
path that it travels,
It
or
goes
rather
right
narrow?
It goes right down there, right where we do line up the goniometer for thumb and beads action.
Does it feel thick?
Thick? Maybe.
Is it sensitive, like when you get a sunburn?
Very sensitive. It's very sensitive to almost like a RSD kind of. I would
Hyperalgesia.
suspect. Yeah, just very sensitive.
Do you guys know that term, hyperalgesia? That is hyperalgesia. Sunburn.
Have you had like any imaging at all?
No, I haven't.
Are you sensitive to light touch?
No.
So it's not allodynia. You guys learned that term?
Other questions? Was it an or a no?
No, it's just looking over.
Just a groan in general. So, quick synopsis from the history group. Kind of important, what you would consider to be the really important findings that help you to come up with differential diagnosis list, and then some of your differential diagnoses, some of the culprits that you're suspecting.
We're just talking out loud right now?
Yep. Yep. No, just talking out loud, as if you had to pick up the phone and call the observation and range of motion group to tell them what you think is going on, and if my next question will be any concerns that you would be alert to as you continue your exam.
Well, repeated motions seem to aggravate her symptoms. She's very observant about her symptoms, which is good, and they seem to have migrated primarily from the upper, this is brachium, right? No, arm brachium, like upper this area, and down to here. It's very interesting that sometimes she'll notice weight symptoms on the opposite hand, but not the opposite arm.
The fact that the soft tissue and nerve lags that she tried to treat herself didn't decrease any of the symptoms can help limit other
The
thoughts.
traction helped for a few hours.
I will say though, with the nerve glides, I think I'm impatient with this. And so I think I found myself just cranking on the
Yeah.
nerve glides. So I'm
Yeah,
not
they're
sure
all
I would
aggressive.
rule out those. I think I just was too aggressive
Okay.
because I'm getting tired of this.
So what are your suspects? What do you think may be the diagnosis or diagnoses? What are you going to try and rule in or rule out?
Cervical stenosis.
Okay.
She has a positive family history of that. So this is thoracic outlet syndrome.
Okay.
Something with her radial nerve, maybe.
Something what?
With her radial nerve.
So a more distal or peripheral nerve entrapment or nerve issue. So this could be coming from the cervical spine, it could be coming from the shoulder, it could be coming from the arm, but it's probably not coming from the wrist. If the doctor referred her with carpal tunnel,
I laugh at him.
not uncommon to see in patients that you got pain in your wrist and hand, that's carpal tunnel, go to the physical therapist. Okay, so that it's not that.
Is there any chance we should look at some cervical disc problem? Because
Okay, I
she
was-
was in that position that she may have had.
I was going to go back to the neck, and you did it for me. So stenosis, what else could be causing symptoms in the arm from the neck besides stenosis? Okay, so we're going to play around with those two in our mind as well as we gather information. Okay. Any red flags? Like saying, ooh, wow, this is something really bad, you should go back to the doctor, or maybe we shouldn't do certain things, or maybe we need to do some further testing.
The only thing is be aware of her.
Whoever first, right?
Just something to be aware of the BPPV for extension.
Okay. What else could give those symptoms of dizziness with altered head positions, especially extension and rotation? Okay, so that's starting to kind of be a flag that's waving in your mind. What about and it's going to affect your ability to do range of motion testing, and so you got to watch. Yellow flags? Did I ask that? Yellow flags. Anything with Barb with yellow flags? Yeah, she's a little crazy. It's that psychosocial
She
emotion.
was willing to stop Candy Crush. That's
So 58 was the level I got to and then I stopped. And I was saying yesterday I was a little embarrassed to admit that I played it, and they thought I was embarrassed that that was as far as I got.
But along that line, she likes to read on the Kindle or play on the iPad, and that may be putting her in postures. Okay.
So just keeping in mind that it's interfering with work a little bit as far as making it.
Okay. So we're starting to see some of those. If this is a patient that's not a physical therapist, they're just a layperson, and they start telling you that I have, and they're throwing out medical terms, and they've already diagnosed themselves and all of that, that could be a yellow flag. And you may have come across patients like that before. They already know what's going to work for them and what's not going to work, and that affects your intervention. Progressive neurologic, was it related to the yellow?
I just have a question that I think would be important to know. What do you normally do when you, just because I don't know much about vertigo, when you have an episode, what do you find that you can do to resolve that? Because if we get in that position, we need to be aware of that.
Yeah, if I get a full-blown episode, I'm out for probably 24, 48 hours flat. Eyes are closed because the world is spinning. I do have meclizine, which is a prescription. I don't know that it does much. It just needs to take time. Now I have had some of the manipulation procedures for the inner ear done. Mike has given me exercises that I don't know I should do, but I'm afraid it's going to bring it on. So I just avoid it. You talked about fear avoidance. I plain out avoid it. It's the most awful feeling ever. So if you get patients with that, be nice to them. It's horrible.
Any progressive neurologic findings that you're concerned about? There's apparent neurologic, or it's in the arm. If this is a neck problem, we have symptoms in the arm. That's the connection. Is it progressive? Is it like a big concern, or is it not surprising? Okay, we can investigate that.
I'm interested that her first pain is starting to get better, and I'm wondering if that's a good thing or a bad thing.
Okay, but it's not something that you think could cause permanent neurologic damage and like a drop wrist problem that she needs a splint, or that she needs to have this addressed. Doesn't sound like it, does it? Or are you completely confused on that one? This isn't progressively going down her arm and getting worse. She's not losing sensation. She doesn't have areas of numbness. She's not dropping things. She's not saying, I hold my coffee cup and it falls out of my hands. I can't hold a pen anymore. So there's no signs of progressive neurologic problems. So we're safe to keep going. Okay? So with those alerts, now it's range of or observation and the range of motion testing. And again, you guys can move around because you're observing. You guys are all observing, if you
We're
want
just gonna
to,
go through
or
some
we can
range
move
of
her.
motion with you. Can you look down as far as you can? And let me know if any of this brings on any of your symptoms. Okay, and look back up.
And back as far as you can.
Okay. Are you having any trouble with that, or you just?
No, I just don't, that's an activity that in that position I don't have to go into because of.
Okay. And then can you look to the side?
That's a little sore
Okay.
in my neck.
On the other side? Okay. Then can you bring your ear down to your shoulder? And back up. On the other side. Good. We're gonna go through some arm motions.
Any symptoms with those? The side bend? Any symptoms with the
Any
side
symptoms?
bend?
Oh, sorry. See how I don't turn very fast. With the side bending, this felt,
Change?
yeah, it felt different. I can't say that it brought on symptoms, but I just feel like that's crunchy.
And when you go the other way, what happens?
It's okay. It just feels tight.
Okay, doesn't increase or decrease?
No.
So go ahead and bring your arms up. And back down. Okay with that? Thumbs out to the side. Bring them all the way up. And back down. Good. Right here. Hug yourself.
Try not to get ahead of you.
And back down. Right here at about a 45-degree angle. And up. And back down. Good. Can you one arm here and one arm here?
So that hurts my left shoulder.
Bring it out.
But I think that's just a matter of I am doing much with my shoulders.
Okay.
That's okay.
Take that out now.
That hurts my left shoulder.
Anything else we should do?
Can you, your abduction muscle,
Yeah.
can you take your upper elbow straight, pull your hands back into, just stand up, put your hand in full interesting section, how do you
I
feel
don't like that.
What do you feel?
That hurts right in here.
Okay. Back off then. How about if you go the other way like this?
That's gonna hurt even more.
Okay.
Actually, that doesn't.
Okay.
I thought it would.
Alright, so now it happens if you,
That, you know what, this starts more this
right,
feeling.
yeah, okay.
This hurts at my elbow.
Okay, so they're different, okay. If you, so if you're here, you feel a little bit of symptoms. What happens if you side bend?
Takes it away.
Thank you.
I gotta do that. You guys gotta figure that out.
So with that group, that was range of motion. That's what, does that represent what you saw, or would you change that at all?
Excess pain.
Excess pain. Okay. What about, what should we write down for observation?
Do you want me to turn
You
this?
can. We're gonna have you do that anyway. She's tough. Give her the truth.
Yeah.
Give her that cold, hard facts.
Forehead.
Okay?
Not all.
So some forward, ooh, I hear a debate. Forward head, well, a little bit.
Forehead is a little bit crisp.
Seems like
So what if Mark really relaxes?
Increase lower cervical function.
What is this? What do you think about that?
So I would strongly encourage you, if you can't see, go to the side, because this is one of those things that once you see it once, the next time you see it, it'll jump out at you. And for us, it's pretty obvious. For you, you haven't seen many, but
So when Barb is really conscious of her posture, she has she's a totally different look. I mean, look, that looks a lot different, doesn't it? And then when she kind of goes and relaxes and not thinking about it, goes into her comfort zone.
come on, you
Changes the dynamics of the neck.
come on, a little Candy Crush going on there.
These darn chocolate things that keep growing. I'm done with that.
So what are you seeing?
What looks like it hurts? King point?
You know what I mean.
That's great. I like that. We'll make that an official method.
King point. Oh, yeah. I thought you said kingpin. I was like, what's the kingpin?
King point.
King point.
Kink.
King point.
Because you're right, whoever said that, it absolutely does. That's real tender.
What level do you think that is, approximately? Maybe say 4.
Is it her?
Pretty high.
What do you think about it? Just looking at it, what do you think about her thoracic spine? What screams to you? Around the shoulders, what else? So, what do you think about this? What jumps out? What do you think about this? I think it moves really good. What do you think? Stiff?
Stiff into what direction? Would you guess? So probably, if we had to guess, would have limited extension, and what effect would that have on her cervical range of motion? Is this where you were going to?
Yeah, exactly.
What would the effect of a limited down glide extension in upper thoracic have on her ability to look up? So if you guys look up as far as you can, how do you get there? Cervical extension and thoracic extension, and that kind of limited down glide is not only upper thoracic, it's a little bit lower cervical as well. So can you extend once for us?
You gonna take me?
Now watch close, because she doesn't like to do it. You get 1 or 2 shots at
Yeah.
this.
Just a little bit.
Where's it come from?
So go back to her vertigo. What is that? Maybe a yellow flag or red flag comes up. What do you think about that? If the motion extension is not coming from thoracic or lower cervical, where's it coming from? So maybe her extension upper cervical is twice as much as it would be normally. We'll put that vertigo. Maybe, right? Maybe vertebral artery.
Yeah. I'm just afraid Mike's gonna ask me to do it again. I'm getting geared up to do it.
Oh my God, that's it.
No, but think back to the lab when we looked at range of motion. We could put the crom on there and measure her motion and say, you're missing 90, or you got 90% of what you should have. And we said, that's nice, but if you look at how she's moving, and you start to put it together, the quality of the motion, where it's coming from, the effect on symptoms, you start to get a whole lot more information, rather than just a number for cervical extension. Doesn't tell you where it's coming from.
When did you start having the episodes of
Vertigo was about 10 years ago was my first one. And I had maybe 4 or 5 that flattened me, but then I figured it out. Haven't had one.
So you really never look up.
I really never look up.
There's something gonna jump on your head.
I have head trauma, but I'm not gonna get vertigo.
So even though she never looks up, does she ever use upper cervical extension? When?
When I'm on my computer.
Computer, Candy Crush, Kindle.
You know, I'm doing yoga, and I used to do it downtown, and I think that probably helped. And then I stopped, and I'm doing it at home. And I am challenging myself when I'm in positions, and it says, extend. I am extending a little bit, where before I never used to.
And as long as you extend with good posture,
Right.
your shoulders back, your hands when you extend, you're in your relaxed posture.
So now as you go back and look at postures, things start to jump out at you a little bit more. Okay? And it starts to become a pattern. Remember, we keep talking to you about patterns. This is another pattern, and you start to see this. And the next barb that you see, you'll be like, oh, yeah, there's that. I bet you. Remember Barb? Yeah, and things will start to make sense. And then you'll say, well, what do we do for Barb? Maybe we could try that here. And now you're kind of into patterns and treatment-based classifications based on your experience. Okay? And now you're probably also saying, I want to get in there and test PIVMs because I think I might see downglide restrictions in thoracic spine and hypermobilities in mid-cervical, and I want to see if we feel those. Hopefully you're thinking that. Anything else with observation? Did we miss anything from yesterday that we talked? Just in different orders. Does that make sense? So now we'll do some motion assessment, the PIVM stuff. So you guys just call now because you started thinking neck and arm, and now we're starting to say, boy, we ought to explore the thoracic spine. So you start thoracic and move to cervical. Can you do a lot in one position? It's completely up to you.
I'm going to do iron stuff. So we're just going to check to see how much motion we have in between the discs. So felt in the upper cervical she was a little stiffer than the mid cervical, and then the lower cervical she was stiff again, and then in the upper thoracic she was stiff.
Did any of that bring any pain?
Yeah, the thoracic was very painful. And with that spot that I get up here, that was
It was painful, like on the thoracic spine, or symptoms in the arm for any?
nothing in the arm.
Hey Barb, could you roll onto your back for me? Yeah. Still do more comfortable for you, probably. Yeah, just go back and forth. Yeah, she's good. Just a little bit. I'm just going to test some of the motion side to side because none of this should be painful, but we know it's uncomfortable. Just do your best to relax.
And that's tender on the right, not with the motion we just.
So I found that right lateral glides were more limited all the way down, pretty much to the same degree at each level. So, which level was tender? C2. But I'm assuming that wasn't the only tender point on your right side.
That one and then the next, so if you were at two and three were tender,
Okay.
the motion didn't bother it, it just, that's what
But
it
those
was.
spots specifically, so C2, C3 were pretty tender. Both sides were pretty stiff, but it was definitely on each segment. Otherwise, the right one was stiff.
Okay. Alright, hi Barb. Jackie. So I'm gonna just do the same motions again, but in a little bit different position.
Okay.
So I'm just gonna raise the table a little bit. Can you scoot back a little bit for me? I'm just gonna put this pillow more under your shoulders. Try and relax. Does this comfortable for you? Just gonna move your neck back and forth. Let me know if there's any symptoms down any side of your either left right arm or left arm.
I remember the whole thing, yeah, I just read that.
Yeah.
I'm just looking at my position as neutral, rotation distraction, similar to cervix, C1, C rotation, similar to Midland. Distraction.
Okay, so for upper, or for flexion, all of her side glides were,
Okay.
all of her side glides were more limited to the right. And as you went down further into the like C6, C7 area, there was more motion actually, bilaterally. So I'm just gonna try a little bit of extension. Avoid. Okay. Okay, so, alright. Next.
Was that giving hand symptoms?
More, at the elbow, more of that original side. And I can't say it was just that position or just everything we've been doing.
What about, are you guys for special tests?
It's kind of the same group.
Okay, you guys gonna do any special tests?
Yeah.
Any neurodynamic tests?
Yeah, someone else is gonna do that. Should I go back?
Proliferation of the cranial-cervical arteries is mentioned in the
I'm just gonna have you slide over this table. I'm just gonna put your eyes on some questions to see if it works.
looking for, one, I want to make sure that when you do neurodynamic testing, you want to make sure you take each component to end range. Okay, so you want to make sure you take the external rotation to end range if they have it. If they have it, if they're not symptomatic there, and you can still go farther. And what you'll feel is as you get to end range, you will feel the very characteristic guarding happen to the hand. Okay.
Try to tweeze it out. Just knows where it is on the neck. Using the neck motions. She said that toward awareness. Said that worse, just like when you're doing the neck testing. Proximal distance. That's okay. Actually, fully supine.
So if she brings her right arm or her shoulder back, releases some things.
Still, one of the tests that we do, special tests that you might want to do on Mark, that we learned already. Maybe some compression distractions, you may want to do that. Let's see. Or
You doing symptomatic?
it's better than this.
Not everybody at once. It's an opportunity to do a special test on somebody who may be positive, who is comfortable.
What did they just find with the upper
Yeah, so maybe
retention test?
report the findings of the upper intention test. You can go ahead. Oh, get ready.
So she had, it was positive for an ulnar median glide on the right side, and she reproduced symptoms in her and female slow. And then when she brought her, when she side bended right, that relieved the symptoms. Or if I let go of the depression in the shoulder, that relieved the symptoms.
Okay. Do some, any compression distractions.
Sorry.
I'm not used to that for me. So let me know if this changes your symptoms at all.
I see, I saw a smile.
So now I'm gonna do the opposite, I'm just gonna push down. So let me know how that feels if one side has done and the other. Go ahead, push.
I'm not feeling it.
Okay.
So I'm gonna go ahead and push. And that hurts. It doesn't necessarily hurt, but it feels different. But you were just barely knocking.
So when somebody's in that posture and she has that hinge point in her neck, depressed, it kind of compresses right there. You saw her neck, goes to that kink. So that's why it probably hurt right there.
Do you want me to turn sideways and do it again?
Can you go up and move so you can see if you want to see the effect of it?
I don't know if you'll do
Maybe
it.
you can maybe kneel on the table.
Yeah.
You can kneel on it.
So would that not be positive if you think it's like not a protection of neural symptoms, but more like a local?
It will, but it's gonna go away as soon as you let go, so that's right.
Right.
But maybe she wasn't really getting out of depression.
Okay.
I would actually even have her sit up and compress her so you're really getting out.
True.
So did you guys all hear that question? And I think this comes up with a lot of the special tests in the spine, both cervical and lumbar. So straight leg raise, let's say, will change it. And you lift their leg, and you get to 70 degrees, and it didn't cause any reproduction of leg symptoms, but it caused back pain. Is that positive or negative? It's negative. Is that useless? No. I mean, that's interesting. Wonder what is going on that would reproduce your back pain with this passive motion. So with this, if you don't get reproduction of arm symptoms, is it negative? Yes. It Is the information useless? No. Does it fit with everything else that you're finding? Sometimes you got to observe what's going on as you do the test. You just don't go, whoa. And when I do that, Mike, you did a good imitation of what's happening that could be reproducing that theme. Okay? So think about the test that way. We don't have many special tests for spine stuff.
And you have Sperling's too, so if that doesn't reproduce it, you can go to a more aggressive testing of that neural frame.
Are you right-handed, correct?
Yes. And that was
I don't
better,
know
but
whether
I
you can
think
get your-
I'm better posture.
your
I'll go like this.
left elbow is
Yeah,
kind of,
I had her sit up in the normal posture.
Yeah.
Yeah, go ahead.
it's blocking them from being able to see what
Oh,
her neck
sorry.
does. So I don't know whether you can. It's gonna be hard.
Just one.
Yeah, you can get up and do one hand.
CPR right now.
So do you see how the stress goes right to
Spot.
She sits up like a little straighter when you do it.
do that?
We'll do the same thing.
Doesn't really compress
It
there.
doesn't, yeah.
God bless.
Sorry.
Barb wants to function today.
Yeah.
It's positive.
You ain't doing that.
Distraction.
So what are you guys thinking? Got some history, some physical exam.
Some of the info seems kind of contradictory, like throughout. Just a couple of things. I don't know, like her range of motion was limited to the right, but then the side glides were limited to the right also, which would indicate maybe like left limitations, left like side bending limitations. So that was kind of, I don't know if that's something that confused me a little bit.
Just
Wasn't expecting this.
see if this helps for you. Do you think it's thoracic outlet? I mean, go back to the three that you listed: cervical, shoulder, and then peripheral neurologic and nerve entrapment. Which one do you think it is? Do you think it's nerve entrapment in the arm, a problem at the shoulder, or is it at the neck? Seems to be neck. And now try and start to sort things out. Well, if it was neck, why would it do this or versus that? So at some point you got to start heading down a road. Otherwise, you're trying to make sense out of multiple diagnoses, and it may not be multiple. Could be, but it sounds like you're thinking this is more cervical spine or neck, cervical thoracic. What, though? So now if you're thinking there, what's the problem? And originally you said, well, this could be disc or this could be stenosis. Think stenosis?
At 5 and 6.
At 5 and 6? Why?
Because she had the positive median nerve glide, so that probably C5 or C6, and then her symptoms are on the back of her hand, which is radial nerve distribution.
What about with motion mobility testing? Do the findings there fit with what you're suspecting? The other way to ask it is there things that don't fit with stenosis and a C5, C6 maybe, or lower cervical issue. This is the point at which we want to make sure this is making sense. So if you guys are all silent and looking confused, this is the key. This is the...
Stenosis would reproduce in extension, but we weren't really getting an extension, so the flexion was not aggravating it.
Okay.
She's generally an extension if she has the forehead, so most of the time she's an extension.
It's C5, C6?
Well,
Distraction helped.
Okay, and would... Does it seem like a disc problem? So remember I said the thing you look for with disc is peripheralization, centralization. What you got to be careful of is not getting confused that peripheral symptoms are an indication of peripheralization. It's repeated movements or positions in one direction cause symptoms to go further down an extremity that when you reverse all of that, it will gradually come back. And there's a restoration of motion in that direction. So you're looking at symptoms peripheralizing or centralizing and motion improving, was she doing that? Or was it kind of a consistent range of motion response and a consistent switch on, switch off with her symptoms? You could turn them on, you could turn them off, versus a dimmer switch that you could gradually bring them on and gradually bring them off. Which was it? It's more the switch, so it doesn't seem like disc. So it seems like neck, but it doesn't seem like disc. So you could start to kind of narrow if we're thinking pathoanatomic. We'll come back and talk treatment-based as well at some point.
Also, if it's disc, sometimes when they come in with like, it's not as insidious as this has seemed like. Whereas it would be a trauma if there's a disc, or they come in and they can say, they can't get out of a certain position. It seems like she still has a good
Right.
amount of
Typical
range.
disc is they go from kind of pretty active and functional to pretty inactive and non-functional within a day. They don't necessarily know that there was a trauma or a mechanism, but it's a rapid onset. So if it's not disc, what's going on with the arm symptoms? Are they coming from her neck?
Yes.
Yeah, I mean, you're not. Some people are nodding yes, but if you're saying you know what I'm going to ask. Why? Make your case. Explain how. If it's not disc, but it is cervical, how is she getting arm symptoms?
Well, it's coming from the spine. If it wasn't coming from the spine, then the things that we were doing at the spine shouldn't really have any bearing
Okay.
on her symptoms. But we were able to change them.
So movements and positions of the neck brought on her arm symptoms or relieved her arm symptoms, but it wasn't that slow, gradual change like a disc would be.
Stenosis could cause compression of the neck.
Okay.
The stenosis could also contribute to the neural tension, the positive neural tension test, right?
Increased neuromechanical sensitivity.
Different way of saying the same thing, probably more accurate.
Okay.
Like same thing, we often say, well, we're going to stretch your nerve. Well, you don't stretch nerves. You get them moving again, you mobilize them, you restore that neuromobility and neurodynamics. But we often say nerve stretching. How so? Explain.
I just picture in my head if there's a closed, like let's say it's for foraminal stenosis, then I would feel like the nerve would have a harder time maybe gliding easily through the canal.
Okay.
If it were closed.
So that could create gliding issues in the canal. What about symptoms on and off with neck positions, side to side with? What were your results? Remind us of your results with neck positions and symptoms with upper limb tension test. Moving towards relieved it, and away made it worse. What's happening in the neuroforamen with those two positions? Closing towards, so you might think that, geez, if it's a neuroforamen stenosis compressing the nerve, that should bring it on, like Sperling's. But it didn't. Actually, moving away did. So opening the foramen, but trying to tug and pull on the nerve components brought on the symptoms. So I'm not saying it's not stenosis. There could certainly be degenerative changes going on there that are restricting neuromobility in the foramen.
Also be restricted other places.
But it could be
like where
restricted
her
other
elbow
places.
tightness was or something.
Right? So you guys are starting to kind of move in and focus in on this. Seems to be a neurodynamics issue that's giving peripheral symptoms that's coming from her neck. If we move away from pathoanatomic and we say mobilize, stabilize, directional specific exercise, traction, unable to group. And we'll put under mobilization all grades 1 through 5 for now, because we haven't kind of separated those out yet in lecture. So you can mobilize, stabilize, directional specific exercise, traction, or I have no idea. Can't group yet. What do you think? I'll help you. Do we need to do any mobilization? Of what? What would a treatment-based classification mobilization be? Where would you go mobilizing? Upper thoracic into what direction? extension, down glide, closing, help that motion. So why would you want to do that, or how would you know this is helping? Why is that good for? Why did you say that? So it might restore some more normal motion in the cervical spine because she's moving her thoracic spine into extension better. What else would help and happen with restoring some down glide in thoracic spine?
Reduce the amount that she has to compensate with her cervical.
Same. I think you're saying the same kind of thing. If we can regain some thoracic extension, we can reduce the amount of cervical extension, mid-cervical extension. Might help with her posture.
She may just get better just by manipulating her thoracic spine and taking that stress off.
Okay, so and you'd see it through improved posture. If you regain thoracic down glide closing extension, will her posture automatically improve? Maybe some, but what else do you need to do? Education. So now that kind of goes in that educate. So we've got an activate and an educate thing going on to help with the thoracic spine. We've got a way to monitor to see whether it's helping, improving. So we can mobilize there. We want to mobilize any other structures. You started doing it with your test. You're doing more neuromobs than neurotesting, but what else needs to be mobilized? Remember, mobilized doesn't just have to be a joint mobilization, a grade 3, grade 4. What else could you mobilize? Yeah, the neural system, because that needs to get moving, or moving better. Anything need to be stabilized? Yeah, that hinge point. Okay? And so we may allow it to be better stabilized by mobilizing the hypomobile segments, but then we could start doing some exercises to try and improve stability. I think a lot of postural education and postural correction is stabilization. Okay? But then you might work on posture with arm movements, posture, neck posture with getting her back into doing upper extremity strengthening that she hasn't been doing.
So you said mobilize the nervous system and also thoracic spine. What about soft tissue? What could be potentially restricted in soft tissue? Or we look at her posture and her forward head. What do you think it's going to be difficult for her to do? What position to get into? Come back, right? To come back in that position. What soft tissue work can she need to do? Yeah, maybe suboccipital muscle, soft tissue, suboccipital. Manipulate the thoracic spine. Do some neurodynamic gliding, flossing of the upper extremity. So now we're getting in a treatment plan, doing some posture education.
You're a sick man.
Do you want to do some distractions?
This is all in his head. This isn't on this computer screen. He's writing down. It's like a walking encyclopedia.
This is my dissertation, by the way.
I have your dissertation? This is, no? Are you all done? You're all done?
Submitted.
Good for you.
Well, we want to do some like distraction as treatment for her since that's
So traction.
Mm-hmm.
Traction's good. Soft tissue, neural dynamics, thoracic manipulation. You guys are on the right track. So you do those types of. So they don't all fit into one classification. Is the point? They may cross boundaries when they're being treated. So nobody fits in the perfect cookie cutter. We can't just say we're going to mobilize her. She just needs stability. She needs mobilization. She needs traction. She needs education.
Also, realize that you can do one intervention that does 2 or 3 of those same things. So we could do a mobilization to the nervous system with a traction, or a retraction, a stabilization. So you can combine things. Does that make sense? Yeah? Those are clear nods? Or if you're confused now, realize, think about the semester. We are now into treatment. Okay, we've finished everything examination-wise except for SI. Except for SI. So you should be able to go out on your fill and examine a patient and come up with a diagnosis. Sort of that same point of last December when you went to the holiday parties and somebody said, so what do I do? And you said, I don't know, ask me in June. You're now at that point with the spine. It's ask me in December. But you should start to be able to come up with some ideas with treatment-based classification. You want to treat? Should we do Because we did yesterday.
It's like Bard field day.
Yeah.
And Mike paces a lot, but he's just itching to do something. I know he's like,
So what I wrote down up there, for if you're real geeky, is a list of references of direct, I think all of those are RCTs, looking at treatment of individuals with neck and arm pain. The top one by Coppetiers is lateral glides for patients with neck and arm pain, a positive median nerve test. The second one down is right for patients with lateral elbow pain and doing lateral cervical glides. These are all single interventions, let's just measure and repost. Needed all in 2012 was a series of doing lateral glides over about 3 weeks, plus essentially a cervical stabilization program and active neuromobilization. Young was a multimodal group where they did what we're about to do, thoracic manipulation, cervical glides. Actually, they did traction and sham traction. There's no difference between the sham and sham traction. So just the manotherapy plus exercise intervention is really what made the difference. I won't bore you with the rest of them, but there's a whole bunch up there. So there's actually pretty good evidence for treating people with this problem.
So Barb's just going to talk to you about yesterday. The class treated her yesterday with traction and nerve glides combination. Just for a few minutes, we kind of came to the conclusion. We started doing traction with neurodynamic gliding with some flossing. Barb, if you wanted to share.
Yeah, it felt great when we were doing it. I could feel I was going into further range with every repetition. And then this morning, when I got up and did that straighten the sheet thing, I had no pain. Now it's come back a little bit now because I kept going, wow, this doesn't hurt. But it definitely just, however many reps they did yesterday helped.
And that was just a little bit of treatment. So with four or three to five treatments of thoracic nips, of soft tissue, of neural gliding, she'd probably get better. She'd get a lot better.
So as soon as you learn your thoracic manips, which I understand you haven't done yet,
Well, we're going to show you,
knock
Barb.
on my door.
so Barb, you get out of bed and make the bed right away?
Yes. Don't you?
Just like all of you, right?
Because when I come home, everything's thrown away. They don't make it go.
Not very
So, if you want to see better or whatever, come on up and. So this is one of the techniques that we're going to show you. Relatively simple one to do as long as you go through the steps of setting somebody up for the technique.
See how Mike negotiates his hand? He's kind of finding.
So I'm just manually sliding her around. So I take her up where she's got increased tension. I feel, as soon as I feel her start to guard into my hand, at her shoulder, I let her wrist go, and I let her shoulder blade go. Okay. Kind of flowing gentle, and she should feel okay.
Is there a reason why you have her neck?
Because usually it's the thoracic feedback. Oh, you know what? I bet if it's the
Time?
the remote desktop, if it was just up for a while, this course is.
There weren't two of you. Would you have her just do active
I would just-
slides and you do traction?
We have a computer table at home for our in our clinic for our laptops. And what I do is I put a pillow on top of my computer and I slide next to the bed and I just leave it open. I'm gonna do the technique as of competition. Just kind of like find the edge and then back. So you can distract and lateral glide at the same time. Okay? This is like grade 3. I'm going basically right to like the old area. Okay. I feel like that one. So I want the person to not have peripheral symptoms when I do this technique. So I back them up shy of where I would get any symptoms.
So as you become a more experienced PT, do you get better and better at whispering? Is that like something that comes with practice? That's not fair.
I think that being in the clinic, you're in a small booth, sometimes curtains, you're talking with a person, you're right in their face, you just kind of develop that, softer.
All three of you were talking, I had no idea what anyone
Right.
was saying. I don't know if that was me or what.
The three of them?
I'm used
Yeah.
to talking to
At
her.
the same
You don't
time.
wanna
And I'm
be-
used to talking really loud so everybody can hear me.
Right. You don't want to be talking to your patient like, "Hi, how are you doing? How are your symptoms?"
Yeah, so his hands and mine are in the mode of treatment with the patient, so it's just one of those things that happen.